Hi, everyone. This is Glenn Woodworth from the Society for Education in Anesthesia. And we have a project to try and bring you educational innovations. We'd like to share these with you so that maybe you can try these in your own institutions. So today, I'd like to welcome Dr. Viji Kurup. She is the professor and vice chair for medical education at the Department of Anesthesiology at Yale. And they've been doing some really interesting things on training their residents in OSCEs, and that's going to be what our discussion topic is for today. So welcome, Viji. Thank you so much for participating with us today.
Thank you so much, Glenn. Thank you for having me. I'm a longtime member of C, so very happy to be involved in a project that would benefit C members.
Awesome. All right, so what we'd like to do is, I understand that during normal operations, you are running several OSCEs for your residents. And so what I'd like to do is just start with maybe how often are you performing these OSCEs?
So this is all pre-COVID. And what we were doing was we were running two time periods in which we used to do the OSCEs. The one in December, we used to run for CA1s and CA2s, and it was mainly an introduction to the OSCE. So mainly just to take out all the mystery out of it and let them know what exactly is an OSCE and, what are they expected to do to be able to perform in an OSCE. And then we used to do one in May, which was for the CA3s. And that we used to run it more in the style of the actual OSCEs, where we used to actually have them assigned to rooms, and then we would run them from room to room and have them get through all of the OSCEs during, one sitting. So that was our, what we've done for the last 2 years.
So just to recap, you were basically running them one time a year. And so as you move through your residency, you get exposed to it once as the CA1, once as a CA2, and then once as a CA3?
That's correct.
Okay, great, fantastic. All right, well, which of the OSCEs did you guys choose to run?
So the AB actually has a lot of resources on their website. So they have a really good document on the types of OSCEs that are usually asked during the exam. And so we basically relied on that. And that the OSCEs that we usually run are, one is on discussion of treatment options and informed consent for a patient. Discussion of a medical error with the patient in terms of disclosure. The other is on discussion of DNR status with the patient and its implications in the perioperative setting. Then there was one on communication with a surgeon on postponing an elective surgery. And then explaining how to design and implement a QI project. Then there were a couple of rooms where we used to have interpretation of, monitors. So we would have one on hemodynamic parameters, as well as one on interpretation of TEE images. And then one room used to be for regional, where they would be, use of an ultrasound probe, the appropriate choice of the probe, as well as identification of structures and being able to get an image. So all of that would be in one room.
Wow, that sounds like a lot. What I've done is I've posted in the chat room a couple of links to the ABA on which OSCEs and their scenarios that they recommend, as well as some of the checklists that they have for performance evaluation. And then I've also posted into the chat room the OSCEs that are being currently run at Yale, which of course mirror those that are recommended by the American Board of Anesthesiology. Well, let's get into the weeds a little bit and talk about how you actually run the OSCEs. So why don't we start with a little bit about the physical space? How many residents are going to be involved, and how are you going to be able to move those residents around?
Yeah, so first of all, I have to acknowledge that this is a team effort. So we do have a really dedicated group of faculty who are involved in this. We have one faculty who does a different part of each of our resident education sessions, and Dr. Mate has been actually the person who coordinates these for the last 2 years that we have been running this. And we have a bunch of other faculty who all bring their expertise. half of these faculty actually have attended the ABA, practice sessions when the ABA was trying to perfect the OSCE. They had invited a number of faculty to participate, and our faculty took advantage of that opportunity. So they did come back and also let all of the other faculty know what exactly the ABA was looking for these OSCEs. So we are very lucky to have that group of faculty here.
Is that course available to, do they offer it at the ABA once a year, twice a year? Is it available to any faculty? You don't have to be an ABA examiner to attend?
So I don't know whether they are doing it right now. So this was when they were beginning to do the OSCEs, and they had a number of practice sessions. And so these faculty were actually being acting as residents for the OSCEs, because they were trying to develop these OSCEs at that time. And so they needed volunteers at that time. So I'm not sure whether they actually do, but I know that for the faculty who do that, they do give a training for faculty who are evaluating the residents for OSCEs.
All right. Well, that might be something for the SCA to consider, is putting together a little video on how to run or for a faculty member to learn how to run an OSCE. So, how many faculty were involved on your OSCE day? How many faculty did you have?
So we have one for every room. So we had about at a minimum 8 faculty. And we've had up to 10 faculty, because sometimes we needed to switch out people because of various reasons, or we would have 2 rooms with the regional person, or we would have 2 rooms with the TEE, so that the residents could get through these sessions quicker. And then you need one person to basically, be the traffic policeman to move people from one room, to the other. So we have every person and which room they're finishing, which room is the next room that they're going to. So when they come back, the person says, okay, next you're going into room 6, or next you're going into room 5.
Right. Did you use a simulation center where you had rooms to use, or how did you get your 8 or 10 rooms that you were going to use?
Correct. So we used actually our multiple. So one was we used our office space, which was in the anesthesia department. So we, requested our faculty that whether we could use the office space. Most of the time we use it for interviews, and we use it for multiple reasons. So we had each of those offices converted into rooms that could be used for these. And we used our sim lab space for the monitors, as well as for the TEE to run the TEE simulations. And then we needed a stretcher for the regional scenarios. So we had to have a room which could accommodate a stretcher, to have a volunteer on it to be able to find different nerves.
Okay, so it sounds like we've got about 10 faculty and maybe a traffic cop that's helping to run the OSCE sessions. Now, were you using standardized patients in your OSCEs?
No. So all of them were done by the faculty. Depending on the scenario, sometimes we had the faculty who was the patient also be the evaluator. And if we had 2 attendings who were doing the same scenario, then we would have one person be the patient, and then the other person actually do the evaluation, because it's just a little bit easier when you're not also having to act. But there are times where we're limited, because this all happens during the evening when there are still cases going on in the OR. And most of the times the faculty are the ones getting the residents out, so you can't have everybody out. So you'll have some people out.
Okay, well, that was great. I'm glad you added that you were doing it in the evening, and that you were having to spring the residents essentially to be able to attend the sessions, and that the challenges are related to that. Well,
and we also made sure that we communicated this to the people running the floor about at least 2 months ahead of time. So what they would do is, during this time, make sure that there were extra CRNAs available that evening, so that, because most of the times the evening is when people, the people dwindle down. And so they just made sure that they had extra CRNAs for the evening shift, to make sure you could get all of the residents that we needed out of the ORs.
Okay. Now, one of the questions I have is you run a resident through a scenario. Did you do any documentation of the resident performance, and how did you handle feedback?
So we did do documentation, and most of these were formative in terms of their feedback. We run mock orals once a year, which has almost like a summative feedback that we give them a pass fail. So the OSCEs until now were run formatively. For this year, our plan was to do a summative one, but with COVID, everything kind of changed. But we do have a checklist, and the attending during their feedback right after the scenario shares that with the resident and lets them know how they've done on each of those and what that checklist looks like, so that there is no ambiguity with how they are being evaluated for the real, for the real OSCEs.
Okay, so you modeled the checklist after what you saw on the ABA website, and then
Content outline.
the attending would be filling out the checklist during the OSCE session, and then at the end would provide verbal feedback as well as go over the checklist with the trainee.
That's correct.
Okay. All right. Well, that sounds great. I think we can all learn about how you were doing that. I hope everybody takes advantage of the ABA resources on developing their OSCEs and some checklist. But of course, all good plans go in the trash because we had COVID happen. And so now things got interesting. So how did you have to respond to trying to continue to do your OSCEs with the restrictions in place because of COVID? And of course, you guys were hit pretty hard.
Right. We were hit very hard. And so for the first few weeks, it was really nobody knew how things were going to pan out. And so our first priority was to make sure that the residents and the faculty were safe. And so what we right at the time when everything was, the university said we can't have any more groups of people in the hospital. So right at that time, we had a Zoom meeting among the leadership, and we defined our goals. And our goals were to make sure that the residents and the faculty were safe, to promote wellness among residents and faculty, and then to introduce learning activities when possible without increasing or making this a source of additional stress, both for the residents who are going to be learning and for the faculty who are going to be teaching. So we really wanted to make sure that we were doing this in a very planful way. And to do this, it takes a village. So we have a very supportive chair, Dr. Roberta Hines, and she's always been very supportive of the educational mission. And she made sure that she would be behind us in whatever way we needed her during this time. So within education, what we did is we created a task force. And there was one person who was assigned the task of figuring out how we would move each aspect of our didactic into the online format. And it wasn't just that person. We had discussions, with everybody to make sure that everybody's opinions and ideas were, taken into account. And so we had to move our didactics, which are weekly didactics, online. Then we had to move our board prep online, and then we had to move our OSCEs online. So that's how we kind of divided our work. For this, we actually we were very fortunate because we had a lot of things that already worked for us because of the work we did in the last few years. So we were using the flipped classroom format for the last 6 years. So we were already making videos, and the residents knew how to use those videos because we were sending that to them ahead of time. Faculty knew how to make videos, and they knew how to use it for, team-based learning activities. So that baseline was already there. Because we were using a lot of technology in our learning, we had already hired a person 4 years ago whose only job was to help with making videos, we had our own media lab. So we were already making a lot of learning objects using this person's help. And this person, Garrett Sandlewski, has been amazing during this time. We already had a Zoom account, so we all knew how to record on Zoom. We had created an app for residents for education on Canvas, and so all of our material were online on a mobile platform.
I think you're making the rest of us jealous already. The resources that you had.
Exactly. So we had actually, we had worked towards, not knowing that we would be hit with something like this, but just to make sure that we were responding to the skills that the residents were coming with, because we have residents who are coming in with skills in online learning. They've all had all sorts of blended learning formats that they've been working with. And if they come to an antiquated department, they're going to wonder what's wrong with us.
Yes.
So
I tell you what, I completely agree with you. So why don't we try to focus a little bit, though, on how you specifically went to implement the OSCEs in a virtual environment. So now you don't have a physical space. And so let's talk a little bit about how you set that up and how were you able to run your OSCE day in a virtual environment.
Right. So we used all of these resources that we had, right? So we had Garrett Sandlewski. So Garrett set up Zoom breakout rooms. So we can have breakout rooms on Zoom. And we had a meeting. We decided, okay, how many breakout rooms can we set up? And for each of these scenarios, we had faculty assigned to them, and we had each of them in a breakout room.
So there's going to be, the Zoom platform allows like sort of a lobby. And then you got the
lobby, and then correct.
And
then different breakout rooms. Correct.
Breakout room was going to be one of the faculty were assigned to that breakout room and run an OSCE scenario in there. And then residents would drop into the breakout room to essentially take the OSCE.
That's correct. Right? And then they would come back to the lobby once they were done with that session.
Right. And they could be redirected at that point to another breakout.
Correct.
Okay. Correct. Well, what was the faculty experience trying to, did the scenario have to be altered, or what did you do differently running the OSCE virtually versus what you would have done in person?
Right. So for the in-person one, what we would do is we would, print out the paper which had these scenarios, and we would give it to the resident. The rooms used to be closed. Faculty is inside. And then they knock the door, and then they enter to give their exam. And so here we had the faculty actually have these scenarios on their screens. And then when the resident comes into that breakout room, they would then share their screen with them and then give them some time to read the scenario and then start the conversation. So I recorded, did the one on disclosure of the medical error with the resident. And so I recorded one of that with the faculty just to give an idea. And we can place that on maybe the Toolbox or the SCA website. And that could be an example. It's just an example of how this was conducted, because I invite them. I say, okay, here I'm going to share my screen. Here's the, scenario. And then we talk over the scenario. And during that time, I am the patient. And then once the scenario is done, I said, okay, now we break character. And now let's, do the debrief. And then I go over the debrief, with them.
Okay, that sounds great.
Share that.
I think that would be great if we could post that as well. I think if you could get written permission from the resident to post that, I think that would be great. We'll see if we can get that up on the SCE website to accompany this this session. Yeah, that sounds great. So were there any of the OSCEs that didn't work in a virtual environment? So you were able to do ones like informed consent and medical error and the DNR discussion. But were any of the OSCEs, were you not able to run them because of the virtual environment?
No, all of them had, they didn't have any issues. We were a little concerned with possible bandwidth and Wi-Fi issues with the residents, because Yale is, has good Wi-Fi, and anything that is run from there will work. But when people are doing this from their homes, that's a little bit more tricky. And we were worried a little bit about the hemodynamic one and the TEE, because it was a video that they had to run. But none of them had issues, because I think, most of the people, our faculty as well as our residents, had good bandwidth in their connections. And so none of them had any issues in terms of running it. There were issues with other people being in the room, right? Like, so now you're doing an OSCE and the residents are at home. So during one of mine, his son came into the room, and then we kind of just talked to his son for a little while. Then the son, left, and then we continued with the OSCE. So not being in a physical space that is private, has the challenges that we kind of had to, anticipate.
Well, I think we've all had challenges doing the virtual meetings with that kind of stuff. So just to kind of circle back on that, you didn't do the regional anesthesia one though, right? Because that required a patient and being able to show how you were going to manipulate a probe. But you did do the hemodynamic monitoring and the interpretation of a TEE. And it sounded like you said that you had to have a video already teed up that they were going to watch. Was that a video that you guys created already in anticipation of this, or you already had it?
Those were the ones that we were already using, and the ABA again has their own, scenario, which has a very good video. They have a one for TEE, as well as they have one for the hemodynamic monitoring. So those, could run pretty well if people wanted to just use those.
Okay, were you using the ABA videos, or did you create your own?
We did those, but we also have our own that we've been using. We didn't want residents to be seeing the same thing every year. So we do have our own videos in terms of monitoring and, hemodynamic parameters, as well as end-tidal CO2, things like that. Yeah.
Okay, so I assume that you did the same thing in terms of evaluation. You still filled out a checklist and you went over it with the resident in the virtual room.
Correct. Yeah.
Did you get any feedback from the residents about how they felt it went doing the OSCEs virtually?
So we've just sent them. It takes a little while for them to all fill out the feedback form. So the feedback form went to both the faculty as well as the residents, and we do this for every session that we have. It's just a routine feedback form after every session that they have. So they know that when they have a session, they have an opportunity to give feedback. But I did talk to a few of them, just because this was the first time that we were doing something like this. I just personally talked to each of them and asked them whether they had any difficulties and whether people had any issues. And everybody said that there wasn't much difference in doing in person versus doing this at a distance. And they felt it didn't really take away from anything. In terms of just, using this function. The only thing is that you need to have a good platform. So there's not, your audio and your video of your transmission needs to be good, because that will otherwise take away from people actually hearing what you're saying, you not being able to hear what the resident is saying. That can be, a problem in terms of running the scenario. But other than that,
that's a good point. I think a lot of us, a lot of the institutions are going to have to think hard about upgrading their technology and platform to be able to do lots of videos going on all of the time and eating up all their bandwidth, because there's going to be a lot of online learning going on. Right. That's great. How about now that you've done it and you're going to run it again next time, what are you going to do differently, if anything? Is there anything you might do differently?
So one thing we felt was that there was a lot of wasted time in between for the faculty, because there were the residents were coming at random times, so they were, some of them came in right at the time. We conducted it from 4:30 to 5:30, and then it went until 6 o'clock when we conducted it. But residents were just coming in at whatever time they wanted, because there was no set schedule, right? And so what I'm thinking is, for the next time, what we would do is we would say resident A would be with faculty A from 4:30 to 4:40, and then from faculty B from 4:40 to 4:60. So that puts an onus on the resident and on the faculty to make sure that they both show up at the right time, because if they don't, then you miss scenario one. If you show up late, you miss scenario one, you miss scenario two. So that gives you an onus to say, okay, if I want to do all of the scenarios, I got to be here on time. And then it also makes sure that people who come in earlier are not pushed off by, people who come in late just because they are, right there to go into. So I felt like there was a little bit of that going on, and just reflecting on the experience, I think that's probably what I would do. So it makes it clearer both to the resident and the faculty what is expected of them.
I think that's a good suggestion. So if you had about 10 rooms, did you have about 10 residents also that during that one session? Is that about the group size that you could do?
Correct. So what we had 10 attendings, but we only had like 6 residents each time. So we expected to have around, at least 10 residents. And I think the problem is because we didn't assign people, that we were not able to do that. I feel if we had assigned them, we would have been, and faculty didn't mind because they were still at home, and it was not as if, they drove all the way and they were not used. But I still felt it was not an optimal use of their time. And there was a little bit of redundancy in that.
So you must have to run the session several times a year to get through your entire CA3 class, for example.
So usually what we do is we run 2 days.
Okay.
Yeah, because the ones we run it in 1 month and then the next month. So the people who are on vacation or who are, doing something else during that month will be able to do the next month. And we usually have a list of people which says you sign up for session 1 or session 2, and make sure that you can attend one of those sessions to make sure you go through all of those. And we were not able to do that this time.
How many residents do you have per class?
20. Now we have actually increased it to, each year we'll be increasing 1 for the next 4 years. So we'll be up to 24. So
you can get it done in 2 sessions, roughly.
Correct. Yes.
Do you make it required? Are they required to attend it? What if they, don't attend? They just didn't show up?
No. So we haven't yet made them mandatory. They are highly encouraged. But we've just been shy of making it mandatory, just, for various reasons. With Yale philosophy is that everybody is an adult learner and people will do things, and that you don't have to have a stick for everything. So far we have not made any of our sessions mandatory. A lot of the attendance is linked to some discretionary monies that they get for a certain amount of attendance. But we haven't yet, said, if you don't attend this, then, this will happen.
Okay, well, that's an interesting carrot, that the more of these sessions that they attend, that they would generate essentially credits or money in the bank. I think that's interesting. I have one last question is, being a vice chair of education, that filling out the milestones can be a little bit challenging. So for example, there are milestones on discussion of a medical error and disclosure of a medical error. Are you planning, or do you currently, or are you planning using any of these OSCEs so that you can actually inform those milestones? Because otherwise, I don't know how you're filling them out.
Correct. Yeah. So I think that the OSCEs would be actually very helpful in informing milestones. So our plan for the next year is to integrate all of these into one document that would be assimilated by the mentor. So every resident who comes in during the first 2 weeks are assigned a preceptor, for their, introduction into the OR. And that person ends up being their mentor for the next 3 years. And that's the person who gets all of the feedback, their daily feedback, anything that comes in from, people who write emails about that resident. And they are like the first line of defense for the resident, because if there's something going on with the resident's personal life, they know about it, so that they can say, okay, this happened and this was happening at the same time. And so they're the mediator between the program and the resident. And so my plan is to have all of these OSCEs for each of these residents go into a file, and the mentor then has access to them and can look at it and say, okay, where are the deficiencies and where are the strengths of this resident, and can use that in giving, we do our quarterly feedback as a mentor, quarterly feedback to the resident, and we can integrate this information into their quarterly feedback. Like right now, all they have is the daily feedback and the ITE results. But I think that this can also be, one of the data points that they would have to discuss with the resident.
That also sounds good. Just as an aside, we have another project. There's a group of people that have been working on entrustable professional activities for residents to evaluate them. And those are mostly case-based. And those cover a very large proportion of the milestones, but there's several that are not, like we discussed about the medical error. So that same group has worked on creating a set of OSCEs and special assessments that could be used, that you could fill out and then map in the background to the milestones, so it automatically is filling out or informing some of the milestones. So that's another interesting project.
Right. The EPAs are another huge area that needs to be, somehow addressed, and we still haven't found our perfect sweet spot of, figuring out how to integrate that.
Well, as I mentioned, there is a national committee that's worked on that and has developed an app for anesthesiology training, and that maybe should be a session for another one of our SCA educational innovation sessions. Well, everybody, I'd really like to thank Dr. Kurup for our great session today and letting us know how they're running their OSCEs. And I think now we should all be convinced that we can be running our OSCEs virtually successfully. So thank you so much for joining us.
Thank you. And I again want to acknowledge all our outstanding faculty who have been an integral part of this, and it would never have been possible without them. Our chair, Dr. Hines, Dr. Mate, Dr. Chawla, Dr. Bardia, Dr. Kinney, Dr. Gutman. So all of them have been, involved in this. Dr. Gall, Dr. Anthony. They've been involved in these OSCEs for the last 2 years, and they've made it an outstanding program.
Yeah, I like what you said. It takes a village. Well, thanks everybody. Thanks for paying attention and listening to this SCA presentation on educational innovation. Thank you so much.
Thank you, Glenn.